Hello, I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson Cancer Center, and welcome to SOHO 2025. Today, it's my pleasure and honor to interview Dr. Guillermo Garcia-Manero, the new chair of the Leukemia Department, and Guillermo just presented the data on a very important trial called the Verona trial in myelodysplastic syndrome. So we would like to go through the details of this study. Welcome to the program, Guillermo.
Thank you, Dr. Kantarjian. It's an honor to be here with you.
So let me ask you this. I think it was a shock to many people that the results of the trial, which is the Verona trial, are negative. And that's because venetoclax in combination with hypomethylating agents had outstanding results in acute myeloid leukemia. So if I can ask you about the Verona trial, what was the design of the trial?
So this was a study for patients with higher risk myelodysplastic syndrome, defined by IPSSR, meaning more than 3 points by that score. So it included patients with 5% blast or more of any age. So you could include patients older than 18. Patients with therapy-related disease were excluded from the trial, and they were not excluded if they were potential candidates for allogeneic stem cell transplantation. This was in general the inclusion-exclusion criteria for this trial.
And what were the treatments in the two arms?
So this was actually a double-blinded trial. One arm was venetoclax with azacitidine, and the control arm was placebo with azacitidine.
And the azacitidine was a full dose, 75 per meter square daily for 7 days. And the venetoclax was how?
It was a 14-day schedule at 400 milligrams.
During induction and the maintenance?
In principle, it was thought to be continued through the whole treatment.
And what were the endpoints of the study?
The main endpoint was overall survival, but there were other endpoints, the most important of which is what we call modified overall response rate.
So what were the results of the trial?
So the study, again, that was designed for overall survival was a negative study. So the median survival of patients treated with venetoclax plus azacitidine was 22 months. And it was basically the same for those patients treated with the placebo and the azacitidine. Now, what is interesting, and again, this is preliminary analysis, we'll be reporting hopefully soon more on this, but that the response rate actually was significantly higher for those patients treated with venetoclax and azacitidine compared to the placebo. Actually, it was around 75% versus 50%.
This is the overall response rate?
Correct.
So that's interesting. The results of the trial were negative. To me, this was shocking. And the question is, what could we have done that might have influenced the results? So let's talk about, for example, the intensity of the azacitidine on both arms. Was it the same or different?
This is a very, very important question, and there was a lot of dialogue with the sponsor. And actually this was led and discovered by you, traditionally in this kind of doublets, always maintain the intensity of the hypomethylating agent at the expense of the second drug. You learned that with the cytarabine, and we applied that to azacitidine. Here, actually, a decision was made to decrease the dose of the azacitidine before decreasing the dose of the venetoclax. So that's an important question. I don't have an answer yet. Hopefully, I will have it, whether this in itself had an impact on the outcome that we saw on the results.
Do you think the toxicity being equivalent suggests that maybe we have used a lower than necessary dose of venetoclax? So it reminds me of the AML trial of 3+7 plus or minus Mylotarg, where the intensity of the chemotherapy was reduced so as not to have excessive toxicity, and that study turned to be negative. Is it a possibility in this study?
It is a possibility, and we have to measure this, that the intensity of the HMA was somehow jeopardized by the combination and the issue that we decrease the dose of the HMA instead of the venetoclax. Traditionally, we have done the reverse. So we have other studies led together with you at MD Anderson, for instance, with oral decitabine venetoclax, where we actually decrease the dose of the venetoclax. If you remember, we did 14 days on the first cycle, and quickly we did 7 or even less in subsequent cycles. We never really touched the dose of the HMA until we really had to. Here we did the reverse.
The other thing that's interesting is in our studies in single-arm trials, we always try to put patients with a blast count of 10% or more, thinking that these are the patients that are really high risk. and by using the combination, we can get them in a marrow CR and move to transplant. In this study, what do you think the proportion of patients who had 5 to 9% blasts were? And if you had to redesign the study, would you restrict it to patients with 10% blast or more so that we can get more patients in remission and move them to transplant?
Actually, a quarter of the patients were in this category of low percentage of blast, so it was not insignificant. And I think probably those patients did not benefit from the therapy for reasons that we may be starting to understand. Data from our colleague in your department, Dr. Simona Cola, have shown, for instance, that BCL2 may not be that expressed in these patients with low blast that have a lot of mutations and therefore had higher risk disease. So maybe we were targeting a population that at least technically could not benefit from BCL2 inhibition. I personally don't think there is a single answer for why the study was totally negative. That's why going deep into subset analysis, etc., will give us hints because we need to move forward, basically. So what we're discussing is the intensity, treating perhaps younger patients that went automatically to transplantation in an unbalanced way without controlling that. Because you are correct, in AML, venetoclax is very effective, but the Viale study actually excluded transplant candidates. It was for an older population. There is actually no reason why we could not have done that in MDS, as MDS is actually a disease of even older individuals compared to AML. So there are many factors here. And then finally, if you allow me, what we have seen over the last 5 years in these big randomized phase 3 studies is that azacitidine had initial results at the beginning, then results decline, but now phase 3 after phase 3, we're seeing response rates with single agent AZA that are 20 to 30%, median survivals that are actually the original 24 months. So the reality is that probably the study was not powered to answer this kind of question of can you be 24 months or 22 with single agent azacitidine. So there are many factors.
So today there are BCL2 inhibitors which the owners of the drugs, the companies, claim to be more effective and safer. Moving forward, if we had to design the next study in MDS, tell me about some of the things you will do to avoid a potential false negative study in this context.
This is a complex question because the authorities, meaning the FDA, may not be totally in line or allowed to do what I would like hypothetically to do. I think that controlling for transplant is very important, and perhaps thinking about the strategies for transplant candidates may be one way to do this. We need to discuss whether an HMA is always a backbone for what we do in high-risk disease. So that will be important because I predict that the study probably was affected by transplant outcomes. That's very important. For sure, removing this group of patients with low blast percentage, they clearly don't benefit. We tried to neutralize the P53 mutation by excluding therapy-related disease, but actually, to my surprise, a quarter of the patients were P53 mutated on the trial. So we know this is a group of patients that likely did not benefit from the intervention. So we start looking at these kind of variables. We could design a study or conduct a study that hopefully will teach us whether adding venetoclax helps or not to these patients.
And one last question about the trial, Guillermo. What was the % of patients who went to transplant and could have, if this proportion was high, could this have rebalanced the benefit to favor the control arm?
It was around, top of my head, around 20% of those patients. But what is interesting is, and I was wrong in my assumption, is this was actually similar in both arms. And what we heard today from Dr. Popat, I believe, we're starting to see that those patients treated with monotherapy HMA that go to transplant with kind of active disease, they are not doing as bad as we thought they did. So if you had asked me hypothetically a couple of years ago, I would say, no, this combo will take more patients to transplant, deeper responses, and then the transplant actually is going to kind of bias the results in a positive way. It turned out to be that, and we need to look at the data in a lot of detail, but it's possible that actually outcomes in the control arm with transplant were not as bad as anticipated. I don't have the proof of this, and that could actually neutralize some of the survival data.
So let me ask you one last question, and I think it was asked to you during the meeting. So if I have a patient who's young, let's say under 65, with a normal karyotype, and that patient has more than 10% blast, would you treat this patient with an HMA-based therapy, or would you use an AML-type therapy to get him in a remission and move to transplant with a curative intent?
I will treat the patient as an AML patient. Let me explain why. So Dr. Bassinet in our group and Dr. Popat at the SOHO meeting a few minutes ago showed very clearly that the intensity of the therapy pre-transplant matters. This is as opposed to other data. And they showed data that adding venetoclax improves the survival, and a little bit of intensity like what you pioneer with low-dose cladribine, cytarabine, venetoclax. That kind of program now is giving us 60 to 70% long-term survival. So we're talking about functional cure. So although the study may be negative, I think we're doing overall progress. So the question is, how do you get there? So in a patient like this that could tolerate higher intensity therapy than just an HMA ven, actually that's what we do in our center, you will treat him with or her with this kind of approach, trying to achieve a deeper response. So there is no doubt about it. So the question in my mind now is that maybe younger transplant candidate, I don't know what younger means, if it's 70 or 65, whatever it is, those patients need a little bit higher intensity therapy. I think venetoclax actually is still a very important part of this combination based on Dr. Bassinet's data. And we go and cure those patients in a significant fraction if we can take them to transplant. For those that are not transplant candidates, then we still need to think about some version of what we have been doing. And I still believe that despite the fact that the study is negative, venetoclax has a role for a subset of these patients.
So we are stuck with HMA-based therapy in AML we were stuck with HMA-based therapy in AML for over 15 years. And now we have the HMA venetoclax, which seems like not a very good standard of care. And in MDS, we have been stuck with the HMAs for close to 20 years. Are there potentially better regimens for both older unfit AML and maybe even in MDS CMML that could beat hypomethylating agents?
Yes. So first of all, I think that, and again, we have no proof of this, but it could be that the next generation of hypomethylating agents, for instance, oral decitabine, cedazuridine, may be better drugs. So Tash hopefully will be presenting an update on the oral DAC-VEN with a response rate of 94% and 50 to 60% complete cytogenetic responses. The question is, how is that possible? One hypothesis is that the cedazuridine may allow better penetration of the decitabine into those cells. I don't know, but that doublet looks very powerful. Now, you pioneered decitabine, and there's been always this question of azacitidine versus decitabine, but the reality is all the studies are done with the hypomethylating agent that we always thought was a little bit perhaps less effective. So it may be actually the choice of the hypomethylating agent, maybe second generation. But the reality is we need to start thinking, we need to move out of these backbones. We cannot do a seventh large randomized, well, an eighth because we're doing the seventh, of an HMA. We need to start thinking about cladribine, CPX. I think we need to start thinking about some type of immunotherapeutics, some new modality. We cannot be stuck on the same model because it's actually been a very depressive approach over the last few years.
So I know we're piloting the cladribine low-dose RC venetoclax in older AML, and there's a pilot of cladribine low-dose RC venetoclax in a modified schedule in MDS CMML. How do the pilot data look so far?
They look outstanding. This is data by Dr. Montalban with in frontline untreated patients like the ones we treated here with Verona. Response rate is over 90%. So it's a small number of patients, but very positive data.
So thank you very much, Dr. Guillermo Garcia-Manero, and I hope you enjoyed the interview. If you have additional questions, you can tweet them or list them in the SOHO Insider, and we can go back and answer those questions.